Okay, we're continuing to talk about pregestational problems, and we're going to talk about cardiac disease. So you should have that handout and a couple of handouts I gave you yesterday, that PowerPoint. Cardiac disease affects about 1 to 4% of all pregnancies. So on the first slide, it talks about the normal physiology associated with pregnancy in the cardiac system. Yes, you do. It's out there. It's out. It was out on shared files. Okay. Every pregnancy affects the cardiac system. How? Tell me what you know already. Increased blood volume. When does that happen? I need you to know the time frame. That's going to be on your test. You're going to have to regurgitate that to me, because it says here on this slide, it says 20 to 32 weeks, but the prime time is 20 to 24 weeks where that max volume is. So if you already have a compromised cardiac system, is it going to be even more taxed with that extra blood volume? I need you to remember that. No, I said 20 to 32 on the slide, and I told you max volume is 20 to 24. So on your test, it could be some range within that time frame. Associated with normal pregnancy changes, increased cardiac output, increased heart rate, increased blood volume we talked about, and your heart compensates during pregnancy by ventricular dilation, hypertrophy, and tachycardia. And these mechanisms provide adequate blood flow to tissues so that your mom is in a state of compensation. So decompensation or congestive heart failure occurs when these mechanisms fail and the heart is no longer able to compensate or cope with the demands of the pregnancy. Could that be a problem for the mom and the fetus? Okay. It says when the heart can no longer compensate, the patient becomes symptomatic with increased activity. Now, if you have symptoms at rest, is that a problem? If you're what? Give me some examples. Short of breath. Good. Good. What? Coughing. Good, Dee Dee. Good. Short of breath, coughing. Okay, so good. The candy helped a little bit, okay? So you have two handouts that I want to go over now. Three, actually it's three. One is cardiovascular signs and symptoms during pregnancy. I gave these out to you yesterday. So on the left-hand side of this handout, it says the normal signs: neck vein pulsation, diffuse displaced apical pulse, split S1, accentuated S2, a third heart sound, a systolic murmur. These are normal during pregnancy. Could have a venous hum, sinus dysrhythmia, peripheral edema. Peripheral edema, where is that? Dallas, where have you got edema? Are you still wearing your rings? Okay. Do you have to get a bigger ring? No? Okay. Okay. Feet and hands. That's peripheral, right? Okay. So abnormal would be neck vein distension. You remember how to check for jugular distension? Cardiomegaly, a heave. I don't care that you know about all those heart sounds. A diastolic murmur, sustained dysrhythmias, clubbing or cyanosis. If your patient experiences cyanosis, what do you think they need to do? How about call the doctor, okay, and get to the hospital. Call 911. Normal symptoms of pregnancy, normal cardiac symptoms. Fatigue, Dallas, okay. Chest pain, have you had any chest pain? Okay, I wouldn't imagine that would be normal either. Dyspnea, why would you have dyspnea? Yeah, the baby's pressing on your diaphragm and your lungs are getting squunched up in there, okay. Orthopnea. A very important question that you need to ask pregnant women is, how many pillows are you sleeping on? How many pillows are you sleeping on? Okay, that's good. So if you're sleeping on 2 or 3, could that be a problem? That we need to check her out and do a little more cardiac evaluation? Because she's having more difficulty breathing at night. Palpitations. Those of you who have been pregnant, do you remember having palpitations during pregnancy? You did? Okay, I don't remember that. Syncope, vasovagal, what is that? Ms. Macruso talked about that. Fainting, yeah, okay. So like positional, kind of, if you lay flat on your back, what happens? Yeah, yeah, it's occluded, blood flow is occluded, and you can sit up or stand up in what? Faint. Okay, that vasovagal response. So, abnormal symptoms at rest: fatigue, chest pain, dyspnea, orthopnea, hyperpnea. All those at rest are not good. Exertional chest pain, not good. You're carrying a load of laundry up and down a set of stairs and you have to stop in the middle. Is that significant? Are you able to walk fewer distance or take fewer steps before you experience shortness of breath and have to stop? Exertional severe dyspnea, orthopnea that's progressive, paroxysmal nocturnal dyspnea, tachycardia greater than 120 beats per minute. Dysrhythmia is an exertional syncope. How do you know if you've had a dysrhythmia? How does it feel inside you? The way I call it is like my heart did a flippity-gibbet, kind of it just kind of turned over, or like it flipped upside down or something and then back, or I don't know, it's just strange inside there. Okay? Should that happen often? No. Okay, the next one is signs of potential complications. So signs and symptoms of cardiac decompensation. So subjective and objective. So one is increasing fatigue or difficulty breathing or both with usual activities. A feeling of smothering. Oh, what's that third one? Okay, I'm going to tell you that's number one. Palpitations, feeling that her heart is racing, edema of face, feet, legs, fingers. Rings don't fit anymore, but the face. And sometimes that puffy face just comes with being pregnant, because when you gain how much weight? 50, 65, 75? Are you going to have a puffy face? Yeah. Okay, objectively, nurse, you have to assess what's their pulse. Is it regular, irregular? Is it weak, rapid? Progressive generalized edema, nurse, you have to assess for that. So should you check for the lower extremities for pitting edema? You did that on postpartum, I hope? You pressed down and the patient said, ouch. Did your finger indent? Crackles at the base of the lungs after 2 inspirations and exhalations. Orthopnea, increasing dyspnea. Respirations greater than or equal to 25. What's normal respirations? Moist, frequent, oh, there it is again, cough. So nurse, you need to notice if that patient's coughing and they don't have any sound like they have any symptoms of sinusy stuff going on. Increasing fatigue. Now, how are you going to objectively assess increasing fatigue? Can you assess that? Okay. Cyanosis, lips and nail beds. You assess that. Then the third handout is the little picture, symptoms of heart disease in pregnancy. Okay, again, at the top of the page on the right-hand side, it says what? The top of the page on the left-hand side, it says, okay, increased respiratory rate, tachycardia. Now we're going to look at our little baby in response to the symptoms the mother is having. Poor fetal heart tone variability from poor tissue perfusion. So if I'm coughing and I have fatigue and my heart is not perfusing, is my placenta perfusing? No. So my baby may be in a state of hypoxia, hope not anoxia. May be experiencing decreased amniotic fluid because of intrauterine growth restriction, not retardation. And edema, lower extremities from poor venous return. Make sure you know all those on your test. Okay, the next slide says the heart cannot tolerate added stress. So the number of women of childbearing age who are experiencing cardiac disease has decreased. Why do you think that is? What's something real significant that we've made an impact in? Strep. So what do we know now? If you have a what? Sore throat, you need to do what? Go to the doctor, get it checked out. And if you know, because you have been previously diagnosed with strep throat, that you have another sore throat, do you postpone going to the doctor, or do you need to go ahead and get that checked out? Because what happens is if you have that strep, it can become systemic. And when it becomes systemic, it can affect the valves of your heart, in particular which one? Mitral valve, okay? And what is the word that it's called that collects on the leaflets? Starts with a V. Yeah, but there's a name for the vegetation. Anybody know that one? Verruca? Miss Murphy didn't say that word? Okay. No, she didn't say it. Okay. Also, postponing pregnancy till older may increase the risk for myocardial infarction during pregnancy. So Dee Dee's friend, that was really scary that she had a pulmonary embolism. Okay. Classification of disability associated with cardiac disease. Class 1, the patient has no symptoms of cardiac insufficiency on exertion. All this is in your book on page 285 and 286 and 287 and 288. So 285 to 288, where a lot of this is. So we're going to go to 285. We're going to talk about that in just a second. Normal levels of activity, no limitations on physical activity. Class 2, symptoms are felt with ordinary exertion, such as physical activity, maybe walking from here to your car. Slight limitation of physical activity, slightly compromised. However, they would be asymptomatic at rest. Okay, next classification is class 3. Symptoms felt during limited activity, moderate to marked limitation of physical activity. They are comfortable at rest, but symptomatic during less than ordinary physical activity. Comfortable at rest, but symptomatic during less than ordinary physical activity. And then class 4. Sorry, I need to sneeze. Symptoms occur during any physical activity, even at rest. Class 4 is even at rest. Experiences angina or signs and symptoms of cardiac insufficiency. Inability to carry out any physical activity without experiencing discomfort. So discomfort increases without any physical activity. Which one do you think is going to cause you the most trouble? Class 4, Class 3, and Class 4. All right, so the next slide talks about the fact that we're going to assess this at 3 months, which is how many weeks gestation? 12 weeks, and again at 7 to 8 months, which is somewhere around 36 to 38 weeks. So the next bullet says that Class 3 and 4 are the highest risk for complications. And unfortunately, these moms have a tendency to have severe anemia associated with their cardiac conditions that also increases the workload on your heart and your cardiac system. So Class 1 and 2 usually have a normal pregnancy with very few complications. The next bullet says that heart disease is the leading cause of non-obstetric maternal mortality. Non-obstetric. So it ranks 4th overall as the cause of maternal death. So what were the first 3? Hypertension, hemorrhage, and infection. Pulmonary embolism. Okay. Infection was 4. Now, so how do you think this patient is going to be managed? As the pregnancy progresses, what are we going to need to tell them? What? Okay, they're going to curtail their activity. So they may be maybe not on bed rest, but do you think that their activity is to some degree going to be self-limiting? Okay. So what are some things that we can do that we know can impact that heart that the patient needs to, should we let them gain 65 or 75 pounds? So they need to be, that weight needs to be monitored. What else do we need to monitor to prevent them from having that significant weight gain. Sodium intake. So what are we going to curtail? No. They can have salt, not at the table. So they salt while they're cooking, but not extra salt at the table. What else do you get out of your diet? Okay, junk food, those little chippy things that Heidi has. What else? What's on your desks? Soda. Carbonated beverages. Canned foods. Where else is sodium? What's high in sodium? Processed. Ooh, yep. Deli meats. You shouldn't be eating those anyway when you're pregnant, should you? Unless they nuke them. What? Yeah. Yoo-hoos. How much caffeine's in that thing?
It's chocolate water. It's supposed to be milk.
I want somebody to go get one and tell me how much caffeine's in it. I can see that. What else? So, are you still a label reader, Emily? Why not? How many of you read labels? Okay, that's so good. All right. I don't even know where I was going with all of that. Okay, so sodium and weight gain we need to monitor that patient for. Okay, so in your book, on page 285, on the left-hand side, under congenital, it talks about congenital heart defects. So we have more women who are coming to childbearing age, who have survived childhood and congenital anomaly, heart congenital anomaly from birth, who are actually becoming pregnant. And so we're managing those patients better because of what? Technology. Technology's better, okay? It says in the middle of that paragraph, congenital heart defects most commonly seen in pregnant women include atrial septal defect. Now, why wasn't that repaired? Ventricular septal defect, why wasn't that repaired? Maybe it was repaired and they are at childbearing age. Patent ductus arteriosus, all those should have been repaired. Coarctation of the aorta and tetralogy of Fallot. You remember all those? Okay, so your patient could have any of those, and because they have been repaired, what are they at risk for? Okay, that was good. Infection. So what is the term of the infection if I have a cardiac disease? Endocarditis? Bacterial endocarditis? So what's something with everybody who had a known mitral valve prolapse or had a cardiac repair, or what is something that they need to receive before they go to the dentist? What is it called? Yeah, SBE prophylaxis. Does that ring a bell? You are preventing subacute bacterial endocarditis. What did you say, Elizabeth? Okay. Y'all need to write that down. SBE prophylaxis. That's going to be on NCLEX, okay? SB, like boy, like beta. Subacute bacterial endocarditis is what you're preventing. So subacute is the first word. Bacterial endocarditis. So it's SBE prophylaxis. However, it's not as acutely treated anymore. So only if they have like a prosthetic valve, or they have a, so if you had a mom who had a atrial septal defect, and how did they repair that? Who remembers? That's a hole between your two atria. Is that a problem? Why? Why is that a problem if we leave that hole there? Okay, because the blood's going to do what back and forth? Shunt. Do y'all remember that? Yeah, so blood's going to mix. Which way is it going to shunt? Which side of the heart has higher pressure? So left to right. So where does the left atria go? Left atria blood goes to the left ventricle to the... This is cardiac. I need y'all to refocus here, y'all. This is not good, okay? I'm scared here. Please come get more candy up here. Heart. Okay? Right atria. Left. Right ventricle. Left atria. Left ventricle. What comes out of the right ventricle? Pulmonary what? Oh my God. Lungs. What comes out of the left ventricle? Okay, good. You should all get an A on that. Everybody should know that. Aorta to all the body, and this doesn't work. Okay. All right. So if I have a hole in here, in you, you're outside breathing, which way is blood going to shunt? Okay, so if it shunts from the left to the right, then the right is going to go in here, and so you're going to have increased blood volume in these chambers, and that's going to go into the lungs. So excess blood in the lungs causes what? I can't share this with Miss Blackwell. She would have apoplexy. You're going to be better, you think? I don't know. Please come get more stuff up here that you need. I don't even know where I was going with that. Okay. So is that probably the least complex of any of those defects? Okay. So do you not remember that Miss Murphy talked about the fact that they would do a cardiac cath and put a little, like an umbrella in there, a shield that would open up, and it would occlude the atria of the hole, so the blood would stop mixing? Because what's the major complication associated with that if I continue to fill your lungs up with that? What? Pulmonary? Okay, how about hypertension? Pulmonary hypertension, do you remember that? That's not good, okay? Oh my gosh. Okay. So let's go back here just a second. If I have a hole in the ventricle, or between the atria and the ventricle, septal defect here, what happens in between the septa here? What, Felicia? Normal physiology of the heart.
What are you asking? Where's the hole? Giant hole.
Okay.
The whole heart.
This is the ventricle. These are the ventricles. Yeah, you're right. It is, essentially. So what goes through here? No. Something else. Yes, conduction. Who said that? Yes, okay, the bundle of His, all those little things in there? Oh, yeah, thank you. So if those septa are not repaired, then you got major problems, right? Okay, so depending on how large the septa holes are, okay, sometimes we can just do a little Dacron shield. Sometimes it's going to have actual internal repair. Now, as the child grows, is this going to have further repair? Okay, so probably this person is going to need to have SBE prophylaxis, right? Will they need to know that? Do they need to wear a medic alert bracelet? Okay, do you think they do? Okay, so what's tetralogy flow? What are they? Yeah, you're right. They're 4 different. I'm not going there today. I'm done. So I need for you to review heart physiology. I may put some extra questions on your test. No, I want you to pass NCLEX. And this response right now is like scaring me, okay? Okay, the next paragraph says, No, I'm not. I'm just scared, okay? For women with congenital heart disease, the implications of pregnancy depend on the specific defect. If the heart defect has been surgically repaired and no evidence of organic heart disease, pregnancy should be undertaken with confidence. With chronic cyanosis, is that a problem? What's that going to do for your baby? Hypoxia, are at increased risk for complications as well as the fetus. Few conditions carry such great risk of complications and death that they can be considered absolute contraindications. These include Eisenmenger syndrome. This is where it leads to that left to right shunt and that pulmonary hypertension. Your book talks about Eisenmenger syndrome on the bottom of 285 and the top of 286. Pulmonary hypertension, not good. Uncorrected coarctation of the aorta. What does that mean? What's coarctation of the aorta? Narrowed area. Good. That's good. Okay. And so is that going to interfere with blood flow to the rest of the body? Okay. Good. Severe aortic stenosis and Marfan syndrome. Who gets Marfan syndrome that you know about? Who has it most often? Athletes. Okay. So these patients need SBE prophylaxis. So we're talking about pregnancy. If they have any invasive procedure during pregnancy, they must have SBE prophylaxis prior to the invasive procedure. Write that down. Okay, I'm talking specifically to pregnancy right now. It may not be all the time because right now they're getting away from every time you go to the dentist to have your teeth cleaned, giving you SBE prophylaxis. So it just depends if you have an artificial valve or what the repair was. What, Elizabeth? Yeah, for these women, all women with known diagnosed cardiac disease, any invasive procedure must receive SBE prophylaxis prior to the procedure. I can't breathe up here. Y'all are scaring me. Okay, any other questions about congenital anomalies? Okay. The next one is rheumatic fever. What causes that? What kind of strep? Group A, beta hemolytic strep. Okay, and we have fewer patients who have had Group A beta hemolytic strep because they're getting their sore throats treated. Okay, again, most often it's the mitral valve. That's in the second paragraph. It talks about the mitral valve. Bless you, mitral valve stenosis. And then the third paragraph says, very important if you remember. Increased blood volume of pregnancy coupled with a pregnant woman's need for increased cardiac output stresses the heart of a woman with mitral stenosis, increases her risk of developing congestive heart failure. Even the woman who has no symptoms at the onset of pregnancy has that risk. So we talked about fatigue. They're also at greater risk for thrombus formation and emboli because of all those clotting factors associated with pregnancy. And atrial fib is very common in these patients as well. So do we need to talk to them about feeling strange fluttering in their heart that they need to notify the healthcare provider? Okay, so mitral valve prolapse is next. Usually asymptomatic, commonly found in women of childbearing age. More common in women than men, runs in families. Mitral valve leaflets tend to prolapse in the left atrium during ventricular systole because the chordae tendineae that support them are long stretched and thin. This produces a characteristic systolic click on auscultation, and the more pronounced can lead to valve regurgitation, producing a systolic murmur. Usually these women tolerate pregnancy well. They may require assurances they can continue with normal activities. Few women experience symptoms, primarily palpitations, chest pain, and dyspnea. So when you experience palpitations, chest pain, and dyspnea, what should you do, pregnant woman? Stop the activity first, and you may need to notify the healthcare provider, especially if it is increasing. Okay? Propranolol, hydrochloride, or Inderol is a good drug that they use. What kind of drug is this? There's a handout that you have that's on drugs. Did I give you all that one? Drugs that are safe during pregnancy, or chart, a little chart. Yes? Okay. First one is digitalis. Crosses the placenta. So what's it going to do in the baby? What does dig do? Slows the heart rate and improves contractility. Very good. It says the fetal concentration of the drug is determined to avoid fetal toxicity. Fetal toxicity exists with maternal overdose, but I don't know. Like I said, it goes in and we can't get it back out, right? It can affect uterine contractility. Procanamide, what is that? Okay, look it up. You need to know it. It crosses the placenta. No teratogenic effects. Verapamil crosses the placenta. Propranolol, Inderol, crosses the placenta. Considered safe for use in pregnancy, non-teratogenic. Heparin versus Coumadin. Heparin does not cross the placenta. If your patient needs anticoagulant therapy, heparin is used. The risk of maternal hemorrhage, preterm birth, stillbirth, prolonged IV use, possibly inducing osteopenia in women. Coumadin or warfarin is associated with fetal anomalies, hemorrhage, mental retardation, blindness, and deafness. So only heparin is used during pregnancy if your patient has to receive anti-embolic medication. Does that make sense to you? I don't know about the efficacy of, what's the one we give in the love handles, Lovenox, or any of those, but Lovenox is a low-dose heparin. Okay, so it probably would be safe. Anyway, so heparin does not cross the placenta, so important for you to remember. Okay, postpartum cardiomyopathy. This is the scary one because all of a sudden, like I've said to you, it's very frightening to me. I think we're using too much oxytocin. We're overloading these pregnant women with IV fluids, and they're ending up in coronary care unit, in CCU, in congestive heart failure after pregnancy. They're trying to breastfeed their baby. They're not able to breastfeed. They're having excess edema, and then they develop this peripartum cardiomyopathy. And so what that affects is their heart, in terms of their ejection fraction, is gravely reduced. Their heart has been damaged from all of that. That should scare you a little bit. Okay? So any of you who go to labor and delivery, you just need to be careful, please. So if you have any of these cardiac symptoms or cardiac diagnoses, should this patient be on oral contraceptives? No, we need to give her an IUD. Probably. That would be the safest. Or she could use a diaphragm. Or he can wear a condom. Of course, he's not going to want to do that, but... Okay, yeah, that's a good idea. We can do a little vasectomy. On page 286, it talks about drug therapy. Again, it talks about heparin. Labor and birth are going to be allowed to normally assume that probability of labor and delivery. Now, are we going to overload this patient with fluids? Can she have an epidural? Yeah, she needs to have an epidural. But you're not going to overload her with 2 liters of fluids in 15 minutes, are you? No. So what's the number one complication associated with epidural anesthesia? Who said that? Hannah. Yes. Hypotension associated with epidural anesthesia? With spinal anesthesia? Hypotension. Why else are you giving all that fluid?
So she can't get Pitocin.
Yeah, she can get Pitocin. So are we going to be judicious in administering Pitocin to this patient with cardiac disease? Yes. Okay. So let's say she went through the labor process just fine. Okay. So it's time for delivery. So is she going to do a closed glottis Valsalva push? Okay. So I had was working with a resident one time, and he had the bed all the way up. She was in stirrups getting ready to deliver the baby, and he took an entire tube of KY jelly and squirted it in her vagina. And I'm thinking, oh my gosh, because we just wanted what? The baby to slide out? Slide out. So might need to use outlet forceps on this patient, because we're not having her push, are we? Unless it's open glottis pushing. Does that make sense to you? Or maybe we'll just schedule her for a cesarean birth with an epidural or spinal anesthesia. Okay. Now, we've had the baby. Is it okay for her to breastfeed this baby? Yes, absolutely. Okay. What do we need to monitor her very closely for? Because what happens in the first 48 hours post-delivery? Okay, we need to monitor for hemorrhaging. That's good. What else? Because that can contribute to anemia if she has anemia, right? She going to need extra iron during pregnancy? Yes, okay. What do we need to monitor her very closely for? That where she could have cardiac compromise and congestive heart failure. What? Fluid shift. Absolutely. Because all that fluid that's out there in the periphery dumps back into the system. And so we have to get rid of it. How do we get rid of it? What's normal? Those of you who are in maternal child who read that the postpartum chapters, what happens in that first 24 to 48 hours as far as that blood volume? How does she get rid of it? Diuresing, especially at night. Night sweats, big ones. Okay. Also increased urination. Okay. All that urine's got to dump. All that fluid's dumping back in. But if I have a compromised cardiovascular system, that's the prime time that I'm going to have another cardiac event. That's on your test. So make sure you remember that. Okay? So 20 to 32 weeks, when that first blood volume is at its max. Again, now, can this patient develop pregnancy-induced hypertension and have problems with hypertension and edema? Can she have a seizure? That's going to compound everything, isn't it? Okay, so your cardiac patients, you have to monitor them very, very closely and carefully. Now, one other thing that I didn't mention is just prophylactically during delivery, what are we going to give this patient? Or right just prior to delivery, what are we going to give her? Say it, Felicia, loud and proud. SB prophylaxis, antibiotics. Okay, now this is not going to predispose the baby to having to have antibiotics in the nursery. Okay, this is the only reason why we're giving it. There's not an infection, it's just that we're preventing this endocarditis in the mother. Everybody clear on that? Wow. Okay, any other questions or comments about cardiac? Let's see. The last slide says that congenital heart I talked about those already, sorry. Women with cardiac disease and pregnancy have increased risk of spontaneous abortion. Just the body can't manage it. I'm on the slide. What? Okay. They also have increased risk of preterm labor and IUGR. Why? Okay, decreased perfusion possibly, and the baby's in a state of hypoxia. Okay, very good. Respiratory acidosis in severe cases may cause fetal distress, especially in that preterm baby. IUGR is a result of decreased PO2 with severe heart disease, and again, the first 24 to 48 hours postpartum through the first week postpartum, they are at risk because all that fluid's dumping back in for having a cardiac event. Does that make sense to you? Okay. You have the last handout of this is home care for women with cardiac decompensation. So you need to talk to them about lifestyle. You need to talk to them about nutrition. You need to talk to them about their understanding of their heart disease. Should be the last one in that section I gave you. You need to identify any stressors that could put excess stress on her heart. Instruct her to report signs of cardiac decompensation or congestive heart failure. This is also in your book on page 287. Generalized edema, distension of neck veins, dyspnea, pulmonary crackles, cough, palpitations, weight gain of 2 pounds in 1 day. So does that mean she's going to be weighing herself every day? Instruct her to be watchful for signs of thromboemboli. She should avoid constipation. Why? Talk with her about she needs several rest periods built in the day. Is this woman going to be working? Probably not. Okay. She's going to need 10 hours of sleep a night, rest 1/2 hour after meals, and this is for class 1 and 2, or rest for most of the day with class 3 and 4. But again, we're talking about quality of life, not quantity, right? And so if she gets pregnant and she wants to have this baby, then we're going to work with her, okay? She needs support groups and community resources, and emphasize the importance of keeping her prenatal visits. Very, very important, right? Pardon me. Okay, any questions about cardiac? Okay, the next handout you should have is the one that I gave you today.